We have a very exciting next presentation by Dr. Burt Nabors. Dr. Burt Nabors is the William Austin Brown Endowed Professor and the Vice Chair for Research and Division Director for Neuro-Oncology at UAB's Heersink School of Medicine. Dr. Nabors will be sharing information about clinical care and current research for our adult NF patients. Dr. Nabors.
Okay, it's a pleasure to be here. And Rennie, y'all can hear me okay?
Yes, we can. Thank you.
All right. So I practice as an adult neuro-oncologist, so trained in neurology, and then my clinical practice is focused on cancers of the nervous system. And we have increasingly begun to work with Dr. Korf and the NF team in both the care of and research for patients with neurofibromatosis. You will note that there is a fair degree of overlap between what I will share with you and what Dr. Korf and Metrock shared. Obviously, there's a lot of commonality. Won't dig too deep into those areas, but we'll try to focus a little more on the adult aspects for evaluation and care. So these are my disclosures. So kind of our objectives this morning, we'll look at adult care in both NF1 and NF2. We'll evaluate some of the therapeutic approaches. I'll touch base on aspects related to clinical trials. Some of the general information will be very similar to what you've heard. And then we will touch base on some specific aspects relative to future development. So as we've heard this morning related to neurofibromatosis type 1, pretty significant incidence, one in every 2,500 to 3,500 patients. It is autosomal dominant. A proportion of patients will just derive as new, and it's related to alterations in the gene called neurofibromin, which is a tumor suppressor gene. Now, as Dr. Korf had indicated to you, there are very specific diagnostic criteria for NF1. These are developed and defined by the National Institutes of Health, the consensus conference going back a number of years, which has been updated with, I think, the most recent in 2021. It's based on specific clinical features of NF1, particularly in maybe an individual who does not have a family member, such as a parent with NF1. A diagnosis is typically established by having at least two of the following criteria, which are 6 or more of the cafe au lait spots, 2 or more neurofibromas, freckling in the axilla or the inguinal region, an optic pathway glioma, leash nodules, which is a little hamartoma, abnormal growth in the iris, the colored part of the eye, or a specific type of bony lesion. If this is a child and has a parent with NF, then 1 or more of these criteria, all that's required. Now, one thing I think we've definitely recognized today is that there are different manifestations over time from birth through adulthood, and that there are specific issues that may become more predominant depending on the age. So we're somewhat focusing on the adult. Obviously, the older adolescent may fall into that category at times. And there are some unique features relative to our adult patients relative to their manifestations, as well as the care of neurofibromatosis in these folks. So obviously, one of the most common manifestations, which occurs in a large proportion of patients, are the cutaneous neurofibromas. And virtually 99% can have issues relative to cutaneous disease. Obviously, this can have a significant impact on quality of life. It can lead to local symptoms such as itching, and there can be fairly tremendous variability in these cutaneous lesions with respect to their size, their location, age when they initiate, numbers of them, as well as associated symptoms. There are a number of local approaches as defined and listed here. Although these are considered benign and typically do not carry a risk of malignant transformation, they can be major problems and sometimes can be the predominant issue for adult patients. Plexiform neurofibromas affect about half of NF1 patients. And as Dr. Metrock indicated, likely to grow more aggressively early. The earlier they grow, the more troublesome they are. There are a couple of MRIs to the right side of this slide. These are in what is called the coronal plane. So it's making a section from the top to the bottom. So this would be the top, this is the bottom. Here is the brain, what we consider the central nervous system. In this bottom panel, we're going down through the upper part of the cervical cord, and we're actually seeing the tops of the lungs. By convention, this is like you're looking up from the feet, or the left is to your right. So this is the left side of the patient. This is the patient's right. We can see this mass that shows up as a bright area. This is not with contrast, but this is a plexiform neurofibroma. We can see in this particular patient more extensive disease spreading through the lateral aspect of the neck and then into the upper part of the chest. Symptoms related to these are obviously based on their location. The majority of the studies that have been active require that the disease to be progressive, meaning changing over time, and or issues related to either disablement of the patient or disfigurement related to tumor location or size. Now, spinal neurofibromas, although again, not malignant, but can become extremely problematic, not just from the issues that we saw related to the plexiform, but as these are within the central nervous system, anything that's growing within this space is going to have to cause a compromise to something that needs to be in that space. So what needs to be within this space is obviously our brain, the brain stem, and the spinal cord. Here are some examples. This is the low part of the spinal cord. This is called the sagittal plane. So again, would be the top of the patient. This would be the bottom. We can see a little bit of the spinal cord here, this darker substance, typically about right here it ends, and things called the nerve roots hang down, look like spaghetti noodles in water, and then they exit the spine at various levels. We can see numerous nodular masses that are growing on these spinal roots as they're exiting the spinal cord. This is the top, the cervical spine, potentially a different patient. Again, we can see nodular bright areas representative on this particular sequence of nodular areas of nerve root tumor. This particular plane is taking a slice through somebody from the front to the back. And so we're getting a look here at the vertebral body. Here is the spinal cord. And these tumors have a characteristic growth along the nerve roots, and they will form a very characteristic dumbbell type shape within this neural foramen, being a little more nodular and bulbular on the side, extending into the soft tissue, as well as on the aspects that extend into the spinal cord. Gliomas are the predominant disease that I take care of every day. Although the majority of gliomas within patients with neurofibromatosis 1 or optic pathway gliomas, they can occur, other gliomas can occur. So gliomas are a cancer or an abnormal proliferation of a type of cell that is present normally within the nervous system called a glial cell. Most people are more familiar and concerned with a group of cells called the neurons, the thinking cells. Typically, we are born with all the neurons that we will get. And as we get older, we may lose some. If we lose too many, we may develop problems related to cognition or higher cognitive functions. Neurons without that ability to proliferate, we rarely see a cancer related to a neuron. The glial cells do retain a capacity to proliferate. Various molecular mechanisms or events can occur over the course of life that can lead to proliferation. When that occurs, they form a tumor of a glial cell we call a glioma. Now, there are different types of glial cells. So there is something called an astrocyte, something called an oligodendrocyte, and something called an ependymal cell. And patients with neurofibromatosis type 1 are at risk for cancers or tumors arising from any of these cell types. So astrocytomas, probably less so oligodendroglioma, but certainly ependymomas. Many times these can be identified and be asymptomatic. There are reports that some can spontaneously regress. They do carry a risk of transformation to a high grade, and by that, we're talking about grades 3 or 4, which are considered the more malignant versions of the disease. Malignant peripheral nerve sheath tumors are less common. However, over the course of life, for patients with NF1, there is a risk. These are transformations of previously lower grade disease. They usually arise in pre-existing or potentially known plexiform or nodular neurofibromas. Things that should alert us that there is an issue would be the primary care physician may be aware that there is a change in symptoms, meaning increase in pain. There may be a change in the consistency or the way the tumor feels. Maybe previously had felt more of a soft nature, taking on a rather hard or solid type of consistency, or if there's any change in the shape or size of the tumor. So certainly a rapid growth of a nodule or an area within an existing known plexiform neurofibromatoma would raise concerns. MRI findings that can be suggestive of malignant transformation maybe include large size, the depth below what's considered the fascial layer, or if the MRI demonstrates necrosis or death of tissue. PET imaging, which is typically with labeled glucose, so we're looking at metabolism or the uptake of glucose by cells. More aggressive or highly growing cells are more likely to take up the radio-labeled glucose, and that may be a modality that could be used to differentiate a transformed to malignant peripheral nerve sheath tumor versus a benign plexiform and nodular. In this particular case, we see a PET scan, we see the whole patient demonstrated. The brain is always hot on a PET scan because the brain and heart have a very high metabolic demand. They take up a lot of the tracer. The bladder, the tracer is excreted in, but we can see relatively large tumor in this individual's right leg. The main treatment of this entity is attempt at resection with relatively wide margins to try to remove as much disease as feasible. Epilepsy or seizures are common in a subpopulation of patients with NF1, probably in the 4 to 7%. Seizures can occur or precipitate at really any age. They are typically more focal, meaning they may not generalize or they may not be complex. Both of those terms imply loss of consciousness or alteration in consciousness. We typically work these up So a patient that presents with a seizure, be they known to have NF1 or not, we would want to image the brain. We would often require or acquire EEG, which is an electrical recording of the brain. And then there are typical labs that are important so we can assess if there are other potential metabolic or electrolyte disturbances that may put someone at risk for a seizure. Management of seizures is actually fairly effective with increasing portfolio of medications that often are much more tolerated in a better fashion than, say, some of our older medicines, such as Dilantin, Tegretol, or phenobarbital. For our adult patients, monitoring of blood pressure is important. Essential hypertension can develop in patients with NF1, as well as a malignancy of the kidney called a pheochromocytoma. In addition, across the age spectrum, we can see renal artery stenosis, which can alter the blood flow to the kidney, resulting in elevations of blood pressure. Elevated blood pressure can be responsible symptomatically for lightheadedness, sometimes headache, often fatigue. As we get older and we accumulate the other issues of aging, such as coronary artery disease, vascular disease, both peripherally as well as in the central nervous system, can increase our risk for other events such as heart attack or stroke. There are some things that are specific for maybe the neurologist or potentially the primary care physician who's following patients. So there can be in patients with NF1, as we touched on, headache related to hypertension, but it can be just headache disorders, seizures, as we've alluded to, and sleep disorders. And these situations related to these issues, we typically treat an NF patient just like we would treat someone without NF1. Medications, physical therapy, surgery, particularly if there are tumors in location that are compromising normal tissue, then those can be considered, particularly for patients who may have a peripheral neuropathy, an irritation, inflammation, or compression of a peripheral nerve, which may lead to a disturbance of sensation in the hands or feet, or even in motor function. There can sometimes be pain that's localized to the fingertips or toes. These can be created from glomus tumors. Here's a scan demonstrating one in the fingertip of this person. So that sometimes needs differentiation from peripheral neuropathies. As Dr. Korf mentioned, and as he is an author of the American College of Medical Genetics and Genomics guidelines related to NF1, there are aspects of care that we need to be aware of as healthcare providers. I think also it's important for patients and families to be aware of these recommendations. Many may be in locations where they do not have, routine access to somebody who has experience in the management or just the routine care related to neurofibromatosis. And so bringing these summary issues to the attention of the primary care provider and potentially seeking out access to specialized centers for evaluation would be important. We've addressed this issue of the malignant peripheral nerve sheath tumor, the MPNST. We've heard actually from Dr. Korf about the concerns related to risk of breast cancer. I mentioned this additional renal or kidney associated cancer, and then just the importance of the management of hypertension, cholesterol, lipid profiles in an effort to reduce potential consequences of vasculopathy. This is troubles with your blood vessel. Examples of those are stroke and heart attack. In addition, important to be aware of care of our bone. Obviously, in adults, this becomes increasingly important, particularly postmenopausal women, and the role of evaluations for osteoporosis, bone loss, supplementation with vitamin D. We've talked about cutaneous neurofibromas and the focus on local therapy. And then we're going to hear a bit later, Dr. Warren, about neurocognitive function. But I think being aware of concerns related to neurocognition, as well as mood and potential mood disturbances, are important to include within the evaluation and care that we're trying to provide for patients with NF1. Now, I want to transition a bit to therapeutic development, and we've heard a good bit from Dr. Metrock. Obviously, we are in a time, fortunately, where there is a lot of activity. We are hopeful that a lot of this activity will result in new therapies, which are more effective for our patients, no matter the form of central nervous system tumor or cancer that they may have, but also they are less associated with side effects or toxicities. This process can be extensive due to advances in technology, as well as the ability to manage information. A lot of compounds can go into the pipeline, which can be in the tens of thousands, as we search for compounds that may be particularly effective for our patients. Dr. Korf indicated the NF Clinical Trials Consortium, gave you an overview of its organizational structure. I highlight that again as this is an important contribution from the Department of Defense, National Institutes of Health, and our federal government to support advances. And as I think you've heard just through today, the need for a very multidisciplinary approach, not just at the clinical end, but at the laboratory and discovery end, will be critical for the advancement of our opportunities with this disease for both patients and families. Now, clinical trials, I think it's always important to understand that these are research studies. They're basically human experiments, and human subjects are typically prospectively, which means going forward in time, assigned to some form of an intervention. The type that I am most involved usually involves something that's a therapeutic. So it may be a cytotoxic form of chemotherapy, it may be a biological therapy, or something that's considered a targeted therapy. Increasingly, we are seeing opportunity for combinations of these types of studies. Often studies so that we can discern if there is benefit or not. May include groups of patients who receive a placebo or maybe a control, which could be a standard therapy and not an experimental therapy. These effects to discern benefit are typically looking at either health-related outcomes, so this would be control of the disease or doing better over a longer period of time, and in some circumstances increasingly may look at quality of life, behavioral improvements, or other non-specific disease control, but outcomes that reflect a benefit to the patient. Dr. Metrock alluded to the issue of inclusion and exclusion. I think I'm not going to detail these specifically. I think she's done that. I think this is important, though, to be aware of, particularly for family of individuals with any form of CNS disease. The reason is often exclusion can be identified based on previous treatments. And so it's important to kind of have, a bigger idea of the direction the current landscape as far as clinical trial opportunity benefits, expectations related to what we may consider a standard available therapy versus one that may be experimental. Various phases, a lot of what we are involved in the neuro-oncology program will often be more early phase type of work. These are often efforts to better understand if we are truly impacting a biological process. So it may be phase 1 type studies, or it is early in the application to humans. Now, a lot of what's been mentioned today for patients with NF, both 1 and 2, are latter phase. The advantage is that many of these are coming from other disease states, so systemic cancers for which a lot is already known about their use in patients and humans. And so the ability to give these, to manage potential side effects, and how the drug works in the body, a lot of that information may already be available. How to find out about clinical trials? Obviously, participating in this activity this morning is one way. Sometimes there's opportunity to discuss this with your specific physician, particularly if they are someone who's knowledgeable or aware of what's going on in neurofibromatosis research. Obviously, looking at the website for the NF Consortium or the DoD grant here at UAB, and then a very useful site is clinicaltrials.gov. It's often a little bit difficult to discern if that's actually open, but it at least gives you an idea of the clinical trial portfolio across the country, locations that may be in proximity to you, and then points of contact. Now, I want to transition a little bit to where we are, at least related to clinical care and drug discovery, particularly initially here for NF1. Ultimately, I think the goal would just be able to block the development of NF-associated tumors. So it would be nice if we identified people early and we were able to deploy a therapy that was very effective in preventing tumor formation and very well tolerated over the long term. Current goal is to really treat more when we are dealing with symptomatic or tumors that have made a transformation. So for glioma, the majority, particularly if they've made a transformation to something that looks to be at the malignant end of the grading scale, we would want to try to arrest its growth or potentially even reverse that so that the tumor is smaller, the burden of the disease is less on a patient and on their family. One of the areas you've heard a lot about is related to MEK inhibitors. I'm not going to specifically detail those, but one of the big advances in cancer care in general, brain cancer care is included, and MNF is very much a part of this, is the advancements in biological understanding of the signaling pathways. These are often called signaling cascades that cells use to either proliferate, to evade the body's immune system, or to become resistant to either the host, the normal processes the body has to control disease, or from therapies. One pathway for which a lot of attention, particularly in NF, is obviously something that is called the RAS-RAF-MAP kinase pathway, which is a stepwise signaling cascade initiated by alterations in molecules such as NF1, which can lead to either removal of an inhibitory effect or an activation event on the cascade where it becomes active when it's not supposed to be active. The vast majority of our therapies have tried to target this specific molecule called MEK. There are new classes of molecules that target the very last step in this cascade called ERK. These are active in a number of cancers as listed here. So not just NF1 associated cancers, and even these are active in NF2 due to the loss of Merlin and the tumor suppressor functions of it, leading to pathway activation, including this particular pathway. A lot of the issues from MEK therapy, MEK inhibitor therapy, as Dr. Metrock alluded to, is related to toxicities. And so the development of new generation MEK inhibitors that carry less toxicity is obviously crucial. These toxicities can include skin, GI, or even cardiac related toxicities. There have been a large number of MEK inhibitors evaluated in plexiform neurofibromatosis studies. I list those. We've heard of them from Dr. Metrock, as well as the collaborations between the consortium group looking to combine either MEK inhibitors or other forms such as mTOR inhibitors with other biological therapies for patients. In this case, here is a portfolio of options available for patients with malignant peripheral nerve sheath tumors. For cutaneous, list options that are more topical. I have scratched the selumetinib study. I think this has either stopped or ended accrual for Dr. Korf. Challenges that the team will come across in patients with cutaneous disease can be related to, when to deploy the treatment, meaning the biology of the disease is often less aggressive. That can mean that therapy may need to go on for a long period of time when a disease is not changing very rapidly. Then we get into concerns related to safety as well as the cost of a therapy. And we're also challenged by trying to discern, is there any benefit to this? What was the benefit to the patient? Were we controlling the disease? Did we do something that led to an improvement for that particular patient? Here's an example of just the effort to try to quantify disease burden in cutaneous neurofibromatosis patient on a selumetinib study, where we can see an effort to try to quantify tumor burden at baseline and then along the course of treatment. And so you can see that this is an effort that does require, aggressive quantification, because otherwise would be very difficult to discern true benefit. We've heard today that often we can just observe tumors, that treatment is not always required. And I think that's certainly the case for those that are intracranial. Surgery can certainly be deployed. Clinical trials, as those are opportunities or eligibility. We allude to off-label therapy. Off-label therapy may be taking a drug such as a MEK inhibitor that's approved and generally available by the FDA, and potentially trying to prescribe that or pursue the utilization of that through a pharmaceutical company patient assistance program. Cytotoxic chemotherapy if there's evidence of malignant transformation, and then obviously focal radiation therapy can be utilized. I want to briefly touch base on neurofibromatosis type 2. Incidence less common, about 1 in 25,000 births. Average age at diagnosis is older, mid-30s, mid-20s. Earlier the diagnosis, usually the more severe the phenotype. A lot of patients with NF2 will develop meningiomas. Meningiomas are typically considered benign tumors of the lining of the brain, but in NF2 patients, they can be troublesome if they are multiple, so multifocal, or if they're in locations that make treatment of these quite difficult. Patients with NF2 also are at risk and can develop acoustic neuromas. These are usually bilateral, as we can see in this particular case. So these two panels, the two to the middle and to the left, are illustrating tumors of the 7th-8th nerve complex, the acoustic neuroma, and then the sagittal plane. So here's the nose, the mouth. This is the front of the patient's, and this is the back of their head. So we can see these little nodular masses arising from the lining of the brain, the dura, relatively larger ones, smaller one, and some intermediate size ones. So from a surgical perspective, these can be quite troublesome just from their multifocality. The diagnostic criteria for NF2 can be bilateral vestibular schwannomas. These are similar to that picture that I just showed you, and first degree relative with NF2 and any of these two following: meningioma, which are the benign tumors from the lining of the brain; ependymoma, which is a glial tumor; schwannoma and other location, or some visual alterations. One question, and I think already addressed today, is this difference between a schwannoma versus a neurofibroma. They are the two most common types of benign nerve sheath tumor, one more predominant in the central nervous system, meaning the schwannoma, and then one more common in the peripheral nervous system, the neurofibroma. Both can undergo malignant transformation. They differ in their origin in that the neurofibroma is integrated into the nerve, peripheral, the cranial nerve, versus the schwannoma, which is from the lining with preservation of the nerve. And there are different surgical techniques that the neurosurgeons use in the management of these. As we've heard for NF1, observation can sometimes be the most appropriate initial step for an NF2 identified tumor. Surgery can also be an option. This needs to be evaluated in the context of risk. That's typically driven by location of the surgery. Many of the NF2 related tumors will be at the base of the skull, so more lower and deeper. The challenge there is many cranial nerves run through that area. And so damage to those cranial nerves can lead to troubles from a neurological function perspective. Cytotoxic chemotherapy, probably less so. There have been studies with a biological therapy called bevacizumab or Avastin, and then clinical trials exist. Bevacizumab, which, as I alluded to, is a biological therapy, has been through a couple of clinical trials, primarily at the Mass General, Scott Plotkin leading this, showing some degree of hearing preservation and some degree of tumor shrinkage. This is an IV medicine given over a very short period, meaning the infusions are 15 to 30 minutes. It works by impairing the ability of tumor cells to have their own vasculature. So it's considered an anti-angiogenic therapy. It is approved for several cancers. It is approved for a more malignant version of brain cancer called glioblastoma. It's approved for metastatic lung cancer as well as colorectal cancers. And generally well tolerated, but it does have side effects, which can include hypertension, deep venous thromboses, and GI issues that, if not picked up and monitored, can become life-threatening. Monitoring is relatively straightforward from a patient's perspective. Not a lot of symptoms that they would notice. The most common reported to me is typically fatigue after the infusion. alluded to targeted therapy earlier as we laid out the cascade and implicated the molecules involved in these signaling cascades as points of control of cell proliferation and growth. Loss of function of the gene implicated in NF2 Merlin, which is a tumor suppressor gene, can also lead to activation of many of these cellular signaling cascades. And they are driven by members that have names like MEK, MET, and ALK. This particular clinical trial is with something called crizotinib, which is an oral receptor tyrosine kinase inhibitor that blocks ALK or ALK, as well as c-MET. Selumetinib, which you've heard a lot about in the NF1 portion, both from Dr. Rock and myself, blocks a different molecule downstream called MEK1 and 2. So where are things going? What are the future directions relative to adult NF care? As stated by others this morning, we need better ways to understand when disease is progressing, metrics either by imaging, clinical, or dynamic studies so that we can know progressive disease. Endpoints of trials are important. We've relied predominantly on disease control or tumor size changes. Other metrics such as components to improve functional outcomes and quality of life can be substitutes and are always clearly important. The ability to more volumetrically quantify tumor burden in an easy and fast as well as reliable manner is critical. Combination therapies are clearly moving forward. We've talked about the need to better arrest tumor development, so prevention studies. And I would say, because there are probably limited centers with expertise in NF care, being able to make that easy for patients is important. So telehealth, I think, will be critical. Here's the team as it relates to adult care, obviously multidisciplinary, spanning a lot of groups. Contact information is included for the NF consortium, and then depending on what Rennie says, thank you, and we can take questions. I know we're kind of right on time here, I believe.
Thank you so much, Dr. Nabors, for that information. I think we do have a few seconds for questions. I believe some of those have been answered in the Q&A section. So let me quickly see if there's any general questions that would make sense for the greater group.
And then if Dr. Korf or others want to jump in to answer, I'm looking, and it does appear like what I'm seeing, I think we've answered.
Yes. The only thing I have a question that was posed kind of separately was vitamin D with NF1. I don't know whether the clinicians who are on the panel today would want to comment on that in terms of when should you start checking for vitamin D? What is the role of vitamin D in NF1 care, and what do you do about that?
So for adults, I'll focus just on the adult population, but I would say we are more likely to screen. I wouldn't say that we would routinely be checking vitamin D. Obviously, in our female population, particularly postmenopausal or postmenopausal, potentially from therapy or treatment, we would try to be concerned with efforts to preserve bone health, bone density. And I think in particularly if they have any form of family history of osteoporosis, grandparent, a parent that has had issues related to bone density. There are studies, I think, that have looked at supplements relative to disease control in many cancer settings. Certainly that's been done in glioma. There has not been any real supplement that we've identified that leads to a better outcome than some other. I do think if we look at other nervous system disorders, the ones that typically come up would be vitamin D and then vitamin B12. So I would say for adults, I would have a low threshold to check, but I don't think I would routinely be checking repetitively.
Yeah, we the consensus recommendations do suggest checking vitamin D levels. I don't usually do it in infants just because it's harder to do the blood draws and not so easy to do the supplementation. I'm not sure there's that much risk there, but I do it in children. I don't do it repeatedly currently, and we do monitor it. I don't recommend putting somebody on vitamin D supplements automatically because you can actually use too much vitamin D. So if we do use supplementation, we keep an eye on levels, but it is something to keep in mind. I don't think it's really known how effective it is in dealing with osteoporosis, which definitely can occur. It certainly wouldn't hurt towards avoiding that. Whether it does completely avoid that, I don't think I could say for sure.
And one more question before we get to Dr. Warren. The question of multivitamins and MEK inhibitor treatment. I know that's come up as something that is not recommended. If somebody is on a medication such as MEK inhibitor, what is the concern with taking a multivitamin in pediatric or adult patients?
Well, for adults, I don't know that I know. I mean, a lot of adults probably take a multivitamin. I don't, I typically don't encourage supplementation with vitamins, particularly when I have, patients with any form of glioma on some form of cytotoxic therapy, like radiation or cytotoxic chemotherapy with a targeted biological. I'm not aware. Dr. Korf, do you have any insights?
The one thing I know about is I believe there actually is vitamin E in the selumetinib preparation.
As a carrier then.
As a carrier, yeah. So because of that, I think vitamin E supplementation is discouraged because you could take too much of it.
And I would agree. That would be one vitamin that you could take too much of. We all are learning something today.